Good afternoon. My name is Guillermo Henry, Arnulfo Henry. To everyone under the sound of my voice, wherever you may be on planet Earth, welcome. We have an exciting presentation for you. One of our own family members going to be presenting. But in a moment, let me talk to you a little bit about you ought not to forget the Middle Passage was the stage of the Atlantic slave trade in which millions of enslaved Africans were forcibly transported to the Americas as part of the Slave Triangle. Ships departed Europe to Africa, drop off their goods and pick up slaves, bring them to the Americas, drop them off and pick up goods and go back to Europe. That's the triangle. We are the Middle Passage in the middle. It was an 80-day voyage with us being shackled together. Could not use the toilet, so we stayed there and did what we need to do. Disease developed. It was stuffy, dark, stinky, no water, very little. 15% of us died and was thrown overboard. And after all of that, Doc Morris, we are here. We are doctors. We are lawyers. We are pastors of some of the flagship church, even though they don't want us there. I need to remind you that Black life does matter. And don't let anybody pretty it up with anything else. We do matter, and we'll be here until Jesus Christ come or he put us to sleep. I got that off my chest. Now let's get to the task at hand. You know, our theme for this year for the Kansas Seventh-day Adventist Church is greater than. The supporting scriptures are Philippians 4:13. I can do all things through Christ who strengthens me. And then from Jesus Christ himself, Matthew 19:26. With men, this is impossible, but with God, say it with me, all things are possible. This is an outreach ministry. We are here not for show only, but if you hear something and you like something, say something. The link that you can meet us at is kansasavenue.org/connect/, and you will have a form there that you can fill out. Okay, now that we're there, I have with me Dr. Jason Pennycook, MD ophthalmologist. I want to tell you a little bit about this gentleman and his family. So when we came here in the 80s, my wife and I, Berta, his parents was here already studying, getting their doctorate, and his wife, Mirta, if you listen, she met my wife and somewhere on the way between school and home, and says, the Lord impressed me to give you this money. All right. And my wife took it and she says, go and tell them you want to register. Now, this is Loma Linda, Black folks showing up, want to register. You get the picture. And my wife was registered, and the rest is history. But while we were going together to school, Jason, you had Junior, which is Eustace Jr., Tricia, and Jason. These three kids was helping their parents. And today, because of Christian home and Christian education, all of them are MDs. All of them in their own specialty. To God be the glory. Eustace and Mirta, you're a blessing. May God continue to bless you. And I promise you, I'll meet you in heaven. All right, Doc, join me here. Where are you? Let me go get you. Here you are. Welcome.
Hi. Thank you. It's nice to be here.
Yes, tell Ida Lines, your wife, and the three kids.
Two kids.
Two kids. All right.
Tell
them we say hello if they're looking. All right. Doc, this is not your first time. By the way, I forget to tell you, Dr. Jason is a member of Kansas Avenue, a member and an ordained elder. Dr. Morris, ordained elder. All right. And he's proud of it. He reminds me all the time. So, Doc,
please don't write me off. Please don't write me off.
We will not do that. So, Doc, I'm gonna ask you just some questions to get you started. And as soon as I finish, I'll go off the screen. Number one, what is glaucoma? Number two, what are the risk factors of glaucoma? Are there common symptoms of glaucoma? The causes,
good question.
Prevention, and why does glaucoma occur? And the final question is, when do I see a doctor regarding glaucoma? I'll see you on the other side for the awesome Q&A that we have set up.
Fantastic. So hi, everyone. It's great to be here. Um, Today is actually World Glaucoma Awareness Day. And that's why I wanted to share with you guys a little bit about this topic that is one of my passions. One of the reasons that I decided to study medicine, and one of the reasons that I decided to specialize in glaucoma. So yeah, we're going to talk about glaucoma and different things. Today, the topics are: how does the eye work? We're going to go back a little bit into that. What is glaucoma and who's at risk? And then I want to talk to you guys a little bit about what's new in glaucoma, and especially in glaucoma therapy. So if you can bear with me, I'm going to start with how does the eye work? And if you remember from our last time, the eye is like a camera, but one of these old cameras. It has different parts, it has different lenses, it has a film. But in the particular case of our eye, instead of having a film like a photographic camera, there's a cable that connects our eye to the brain. That cable is the optic nerve. And when we're talking about glaucoma specifically, the problem is that the optic nerve becomes damaged because of different factors, but specifically or especially through one factor that we can modify. And that factor is the intraocular pressure. Intraocular pressure being the amount of pressure that is inside of the eye and that helps the eye to keep its shape and the different spaces. So, what is glaucoma and who is at risk? And this is one of the most difficult questions to answer. What is glaucoma? It's difficult to answer because usually when we think of a disease, we think of one cause leading to one effect. And in the case of glaucoma, that is not so. Glaucoma is in reality a group of diseases. It's a different cohort, a lot of different diseases that all end up with one characteristic sign, that is death of the optic nerve and the cells that form it. So you can have glaucoma because of different reasons. And most of those reasons, in fact, we don't know what they are. We don't really know where they come from, but they have one endpoint in common. And that endpoint is that the optic nerve becomes cupped. We need to talk about numbers a little bit. Glaucoma is the fourth largest cause of vision loss around the world. And when it comes to African Americans, is the leading cause of irreversible blindness. It is said that people that are from African descent are at a higher risk of developing glaucoma. When we spoke about this last time, we mentioned that there's some issues with not only with the research that was done to reach this conclusion, but also with the access that we sometimes get to healthcare. But having said that, and in spite of that, the reality is that as Black people, we're at a higher risk of becoming blind because of glaucoma. And that's one of the reasons why we need to talk about it, and we need to make sure that not only ourselves, but our family members are aware of this disease and of what to do and how to prevent it. One of the main factors or main problems with glaucoma is that you will not feel that you have glaucoma until it's usually too late. You will not see the signs, you will not feel any symptoms until it's so advanced that there's not too much that you can do about it. Whatever vision is lost in glaucoma is usually impossible to recover. And because the vision is lost from the outside to the center, we don't usually notice what's going on. Common symptoms for glaucoma are basically people that bump into things. You know, your peripheral vision is affected, so you might hit the door or not notice things that are on the floor, or not notice that car that is coming until it's a little bit closer to call. That sort of thing is something that can help us think that we might have glaucoma. But because this happens in other diseases as well, it's not a fast telltale of glaucoma. Because you don't feel any symptoms, you might not be inclined to seek help. And because you don't get to a doctor, you might not be diagnosed on time. So how is glaucoma diagnosed for most people? Most people are diagnosed with glaucoma when they're going to their ophthalmologist to check on their eyesight for something else, not specifically for glaucoma. I'd like to show a video now So you guys can take a look for a quick second. And now I'm going to explain a little bit more about what glaucoma is. So in glaucoma, well, inside of the eye, there's a liquid that is created. This liquid is made behind the iris. It goes through the pupil into an anterior chamber and then exits the eye through the corner between the cornea and the iris. When there's more resistance in that corner, there's an elevation in the intraocular pressure. And that goes all over the eye. It doesn't just happen in the front part of the eye. It goes all the way to the back, and it affects the part that is more sensitive to pressure, which is the optic nerve. And that creates cupping. And once we get to cupping, that's when we start losing our sight peripherally, and finally in the center. So once again, there's a liquid that's formed inside of the eye. This liquid is there to maintain normal pressure. But after there's resistance to the exit of this liquid, there's a buildup of pressure, and that buildup of pressure will then create problems in the optic nerve head. That's what we can see. What this will imply is that the optic nerve will lose some of the circulation, some oxygen. It will also lose some of the cells that form it, and this is what causes glaucoma. So, risk factors for glaucoma. There's a lot of risk factors, and one of my favorite tools is a calculator where we can actually go and see how many risk factors we have and score points for each one. Now, there's two basic types of glaucoma. There's open angle glaucoma and angle closer glaucoma. Angle being that part of the eye where the liquid is supposed to exit. We're going to focus today in open angle glaucoma because this is the one that is most common. It affects 90% of glaucoma is open angle glaucoma, and it's also the type of glaucoma that mostly affects African Americans. So I'm just going to go through some of the risk factors, and I want to highlight that in case of race, being of African descent, African American, or from the Caribbean, that's where we are classified as the group in highest risk of having glaucoma. Glaucoma is a disease that is also age-related. So if by the time that you find some signs, the younger that you are, the higher risk you have of becoming blind because of glaucoma. It's most frequent in men than in women, but women are at a higher risk of becoming blind from glaucoma. So you're at a higher risk of having glaucoma if you're a man, but you're at a higher risk of becoming blind because of glaucoma if you're a woman. Why? Because men, we're not as strong, and we seek help a lot faster, and that's why we get more treatment, better treatment, and we don't become blind as quickly. You're going to see a lot of different factors there that are factors that are mostly measured by your ophthalmologist. And I don't want to go into detail with these, but for instance, if you have myopia, you might be at risk. Or if you're on the other scale and you have hyperopia, you might have risk as well. There's different things that your doctor needs to find and look specifically in your eye. And once he does that, he'll put you into this risk calculator and find out if you have risk. And we can classify risk as low, moderate, or high. And people that are at a high risk have a higher risk of becoming blind or losing a significant part of their eyesight within the 5 years after they perform this examination. If you're on the lower end, then there's less than 10% risk of you losing eyesight because of your risk during the next 5 years. What to do, how to know all of these factors or where you fit. You need to visit a doctor so they can check all of these things and know what kind of risk you're facing. This is something that can be done either with an optometrist or an ophthalmologist without any problems. So having said that, I want to talk about what's new in glaucoma. And when we talk about what's new in glaucoma, I'm going to talk about three things. These are the three main focuses of glaucoma right now. The first two have to do with what's happening now, and the last one is what's going to happen in the near future. So first, we're going to talk about new therapies. The newer therapies are all about this. Um, you might have the same drugs that you've been using for a long time, but now we have preservative free drops or preservative free versions of these drops. And this is very important because most of the time, the preservative that is used in the eye drops is the most irritating part of an eye drop. So if we can have drops that are preservative free, the eyes won't be as red, the eyes won't be as, they won't feel as awkward, and this will help not only compliance, but it will help with quality of life of the patient. Then we have two different types of drugs that have actually been developed over the last 5 years. For many, many years, for almost 20 years, we didn't have any new drugs for glaucoma treatment. But now in the last 5 years, we've developed two new types. One are rho kinase inhibitors, and the other type are nitric oxide donors. These are already available for prescription, and your doctor would know if you're a good candidate for those or not. Usually, candidates for these drugs are on either on the very beginning of their journey with glaucoma, so this is your first therapy, or right at the very end, right before we start with thinking about surgery. That's what we're doing. Speaking about of surgery, this is the second development. Microinvasive glaucoma surgery is in a boom right now, and these are different devices that can be used to reduce the amount of eye drops that you need to use to control glaucoma by 1 or 2 drops for 2 or 3 years, and sometimes even a little bit more than that, and are done through surgery that is not as invasive as traditional glaucoma surgery. So if you're going to your doctor, you need to talk to them about preservative-free drops. You need to talk to them about newer types of medications, and also need to talk to them about what your options are with microinvasive glaucoma surgery. These are surgeries that are usually better fit for patients that are with either a mild or moderate case of glaucoma. Once the severity is too high, then these drops are not, this surgeries are not as effective. And finally, there's newer laser therapies that are especially beneficial for African Americans and for patients that are at the beginning of glaucoma. It used to be that once you were diagnosed with glaucoma, we would start you on an eye drop that would usually have side effects that went from a red, itchy eye to several, inflammation and very uncomfortable and quality of life diminishing symptoms. So what we've developed over the last few years as well is, and what we found out through research is that certain laser therapies are even better than some eye drops when we do it at the right time. And you can save yourselves from 2 or 3 years of eye drops, even a little bit more in some cases, by using certain types of laser therapy. This might actually it might actually have the benefit of saving you from having to pay for the eye drops monthly and pay for itself in less than a year in some cases. If you're a good candidate for this, your doctor needs to check your eye. He needs to check the angle of your eye. And if you're a good candidate for this, please don't hesitate. Go for laser therapy. I was in a panel a few days ago, and somebody asked the rest of the panel, if you're a glaucoma specialist today and you were to if you were to choose what type of therapy you would get for yourself, what would you do? And all of the glaucoma specialists went for laser therapy. That's the newer thing. That's what we should be aiming for right now. And then when we talk about precision medicine or the future of glaucoma, we're coming to a point where by just taking an exam of your blood, a blood test, we can find out what your genetic profile is. And that has very important implications. We've noticed that certain genetic profiles respond better to a surgical first approach than the drugs. Then other genetic profiles have a better response to certain type of drugs. Certain mutations have been linked to malignancy after certain surgeries, and in other mutations, we know before you even go into surgery if that surgery is going to actually be helpful or if it's going to fail in 2 or 3 months instead of 2 or 3 decades. So Precision medicine is what's coming new to glaucoma, and the way that we're applying this comes in different ways. It might be from having your eye pressure checked at home with new devices and creating a profile that fits you and fits how your pressure behaves over 24 hours, or it can come in a way as a blood test. So these are the things that I wanted to share with you guys today. Um, Once again, in summary, there's newer drugs that are there to help with your quality of life. There's new surgical procedures that can help eliminate the use of drugs, or reduce the number of drugs of eye drops that you need to take. And then there's things like lasers that are an excellent alternative to the traditional treatment. Happy to take your questions now.
All right, Doc, that was awesome. Right out the gate. First question on the screen for you. Will insurance cover preservative-free eye drops?
In most cases, it will. Companies are very interested in just leaving behind the other type of drugs. So yes, in most cases, it will.
All right. I have a question for you that I read it to you. What's the normal eye pressure?
Normal eye pressure goes between 10 and 21 mercury millimeters. Usually, the closer you are to 10 is better. You won't feel any pain. You won't feel any symptoms if your eye pressure is under 30 or 33. Is about the pressure where you actually start feeling pain. But you will suffer from glaucoma effects if it's anywhere over 21. Once you have glaucoma, certain patients will actually show damage or effects of high pressure, even at lower pressures, lower than 21. So there's a concept that is called the target pressure. And what that is that once you've identified a patient with glaucoma, you want to make sure that their pressure drops at least by 30%. And if it's more advanced, you want to, the magic number is 12. You want to get the patients as near to 12 or lower as you can. If you can get a patient to have a intraocular pressure of 12, then progression in glaucoma will take several decades, and you won't have a problem because of glaucoma.
Before I get to the next question, just a follow-up to this one. Is there a correlation between blood pressure and eye pressure?
Yes and no. So we've seen that patients that have high pressure may have a higher rate of intraocular pressure, but it's not a direct relationship where I can say, if I take my blood pressure and my blood pressure is 150 over 90 today, then my eye pressure is going to be 23. You can't really make that association, but we know that people that suffer from high blood pressure are at a higher risk of high intraocular pressure.
Next question. Can I purchase a piece of equipment that I can take my own eye pressure at home?
That's one of the things that I was talking about in the new precision medicine approach. There's an eye checker. It's called the iCare, and it's the home edition. You can take your eye pressure at home with that. Having said that, this is something that you should only buy if you've been diagnosed with glaucoma, because this is we're talking about $3,000 or $4,000 for this device.
Okay.
And it makes no sense to buy it just to find out if you have it or not. So if you have glaucoma, then you might even get insurance to cover it because it's a good investment. But if you don't have glaucoma, then just visit your doctor once a year, especially if you're over 40 years old, and we'll find out if you have high intraocular pressure or not.
Could you explain? This is from Dr. Gordon. Could you explain the difference between cataract and glaucoma?
Of course. So cataract is a problem with the lens that is inside of the eye. Glaucoma is a problem where the whole eye is affected because of the pressure.
Yes.
And specifically the nerve starts to die off. Cataract is a single problem that can be easily solved with one surgery. So we don't need to worry about cataract in the sense that we're all going to have cataracts, just like we're all going to have white hair at some point. That's a fact of life. We're all going to have cataracts at one point or another, and hopefully we won't all have cataracts that are visually significant. But if you have a cataract that is visually significant, then one surgery will take care of that problem, and that's it. So cataract is the main reason for blindness that is reversible.
Okay.
Glaucoma, on the other hand, is not reversible. Glaucoma, on the other hand, you won't find out that you have it until it's too late. And it can only be treated by lowering the intraocular pressure. But because there's several causes of glaucoma, lowering the intraocular pressure might not be enough. It's the only thing we can do, but it might not be enough to save your vision, and we can't make you recover vision, unlike cataract. So cataract is more common. It's a natural process of aging in the eye. It's something that is easily treated and is completely reversible. And glaucoma is less common, but won't be reversible and needs to be diagnosed by your eye doctor. You can have a cataract diagnosed by any physician, but but glaucoma will only be diagnosed by an eye doctor.
I may miss it. Can children get glaucoma, and what are risks? Can it be
That's
delayed?
an excellent question. Yes, children can get glaucoma, but usually the type of glaucoma that they get is different from the type of glaucoma that adults get. So congenital glaucoma is it's a whole range of diseases that affect not only the nerve, all the tissues in the eye are affected. Treatments are very similar to those in adults. Thank God it's very rare. And you'll notice that the way that you notice these kids are because they have a triad. Usually they are light. They have photophobia, which means that light affects them. They cry whenever there's a bright light.
Mm-hmm.
They'll have big eyes. Their eyes grow because the eye is a lot more elastic at that age. Instead of just keeping the pressure down, the eye will start to grow, and the corneas will go big and sometimes change the color of the cornea. The cornea will become bluish. Your physician, your pediatrician, is trying to note these things and to highlight them. And kids don't go. Kids with glaucoma don't go unnoticed. Usually, adults with glaucoma do go unnoticed. But these are two completely different diseases that are both called glaucoma.
Will you need RX to cover the device that measures the eye pressure?
Probably. I wouldn't know.
All right.
But
Next.
probably.
Remember Dr. Gordon asked a question before she said thank you. Yes.
You're welcome, Dr.
And
Gordon.
then here we go. Is it true that glaucoma can be treated with marijuana? Tell me yes, doc, so I can go pick up my stash.
No, it can't be treated with glaucoma, with marijuana. No. There was a big push when marijuana became legal. A big push was to use it with terminal glaucoma patients. Mm-hmm. Terminal glaucoma patients are in a lot of pain, and because they were in a lot of pain, marijuana would help to manage that pain. Some people even said that it lowers intraocular pressure a little bit, but it doesn't do it to a degree where it's actually useful, where it actually prevents blindness, where it actually prevents progression of the disease. Mm-hmm. It's been used as a pain management option, not as a treatment for glaucoma.
Next one coming up is, can glaucoma be prevented, and is there a cure? I know you mentioned part of it, but the first part.
Okay, so that's an excellent question. You cannot prevent glaucoma, but you can prevent people going blind because of glaucoma. So we can't actually stop glaucoma from happening, but if we catch it on time, we can make sure that you never go blind because of it.
Oh,
And that's the actual goal in this, is to make it progress so slowly that you'll, by the time that you're 200 years old, that's when you'll become blind of glaucoma. That's our goal, to just move the goal line, move the end point of blindness as far away as possible from you. And that's why we're a lot more aggressive with younger patients than what we are with older patients. There's no cure for glaucoma currently. Having said that, I'll go back to what I mentioned about precision medicine. We're learning in the last 3 years, we've learned so much about the genetics of glaucoma that there might be a gene or two that can be switched and help us to control or stop glaucoma completely. That's on the horizon. Another part of precision medicine right now has to do with regeneration of tissues. So we might not be able to stop glaucoma from happening, but in the not so far future, we might be able to inject something and help your optic nerve grow back. And then, so that's the exciting part about this. We're not there yet, but we're getting closer to that sort of situation where we can reverse glaucoma, or we can stop it from progressing effectively.
Can I have glaucoma from diabetes?
Yes. So, like I mentioned, there's different types of glaucoma, and most of what I mentioned today has to do with open-angle glaucoma, which is a particular disease where glaucoma is the main problem. However, because of diabetes, you can have a different type of glaucoma that is called neovascular glaucoma. Neovascular glaucoma happens when, because of a lack of oxygen, your eye creates some blood vessels that have a very low quality. And just like these vessels happen in the retina, and they produce intraocular bleeding and might even detach the retina from its place. These vessels can also happen around the drainage of the eye, around the angle of the eye, and they can block it and also bleed into the interior of the eye. All this creates a increase in the intraocular pressure that will destroy the nerve, and we're back into glaucoma. Okay. So it's very common to have patients that have diabetes that has not been controlled, have as one of their complications something that we call neovascular glaucoma. Neovascular glaucoma can be prevented in the same way that we prevent diabetes. The way that we prevent neovascular glaucoma from happening in patients with diabetes is the same thing that we do for treatment of diabetes, which means controlling your blood your blood glucose. And if we get to a point where we start to see that your eye is being affected because of diabetes, there's lasers that we can use to eliminate the signal that creates those blood vessels. And there's also some injections that we can use to eliminate that chemical signal. So by the time we have a patient with neovascular glaucoma due to diabetes, we're talking about a patient that we failed as a healthcare system for 25 or 30 years. We failed to prevent diabetes. We failed to control diabetes. We failed to prevent diabetic retinopathy. We failed to prevent more bleeding inside of the eye, and we failed to prevent neovascular glaucoma. And this is something that obviously has to happen in teamwork, right? Physician and patient. So yes, you can have a different type of glaucoma from diabetes. And the key here is be faithful with your treatment and your checkups.
All right, Doc, here we go. So, Doc, before I go on, there's a lot of questions and answers. Get to all of them, but stay close by so when I get sick, I can come to you and you can do all of those fancy stuff on me, okay? Here we go.
I'll be glad to.
Here's another one. Cartbill. Thanks so much to both of you, all right, for taking the time. All right, here we go. This is informative.
Thank you.
Dr. Gordon, again, she said, what role does nutrition and supplements play in healing and prevention of glaucoma?
You know, that's an excellent question. I actually knew I was going to get this question, so I went and looked specifically for a paper on lifestyle, nutrition, and glaucoma.
All right, Doc.
So here's what I found from this review. Eat well, eat healthy, and you won't have a lot of the problems that lead to glaucoma. Smoking is a risk factor, so don't smoke, and you reduce your risk of glaucoma. Supplements, vitamins have probably, maybe, let's hope so, some sort of effect, delivering antioxidants to the inside of the eye. You would probably need industrial quantities to actually get some of that to go into the eye. But if you're doing it, then it's good for other parts of your body. Go for it. Nutrition is, the healthier you eat, the better protected, the stronger your eye will be. The issue here in all of this that I'm saying is that there's research is not good enough to actually say this meal will protect you in this way. This food will affect you in this way. We don't have enough research, and we don't have research that is good enough to actually give us an answer with that. All right. But we have common sense, and with common sense, we can say eat healthy, do your supplements, and they will help. But it's not there won't be a magic pill for this.
So Doc, there's a preamble to the question. So I'll do the preamble and bring up the question. What's the best eye drop? Here is the question. Do you know any eye drops that cure cataracts? Janet. So it's 2. What's the best eye drop, and do you know any that cure cataract?
Okay. Cataract surgery is, I think, a $10 billion industry only in the US. And then you have to add Europe and the rest of the world. So we're talking about a lot of money here. There's no eye drop that works. And whenever there's an eye drop that works, I'm pretty sure that these companies are going to be quick to buy it off and hide it under somewhere. There's a lot of research going on that right now, because whoever comes up with an effective eye drop cure for cataracts is going to be very rich very soon. But there's nothing in the market yet. There are, however, a lot of alternative medicine eye drops out there that you can get on eBay or Amazon or one of these. I wouldn't recommend them. They are the equivalent of, you guys remember how with COVID, a lot of people were injecting some stuff and finding all sorts of drugs to try to prevent it, and there was just no research behind it. There's some eye drops that are like that for cataract. And I say this knowing that if you trust me and you trust the medical society and physicians in general, then you'll take my word for it. If you don't, then I might not be able to convince you. But let me just say that the eye drops are dangerous because they take away the chance for you to actually get treatment. There's effective, good treatment for the cataracts. And even though there's research for those eye drops, there's nothing out there yet.
All right, here we go. Is glaucoma hereditary?
Yes. If you have a first-degree family member with glaucoma, you have a much higher risk of developing glaucoma. Some people say 3 times, some people say 8 times more likely to have glaucoma if you have a first-degree family member with glaucoma. And that's, once again, when we're talking about glaucoma, we're talking about a whole lot of diseases that have one common endpoint in common. And some of those are definitely hereditary or genetic. That's why precision medicine is important.
All right, here we go. Is there anything, sign, that I can notice? And I think you mentioned this before, right, Doc?
Yeah, so we try to tell patients that if they're noticing that they're bumping into things, then that might be a sign. But usually that's a late sign of glaucoma, not an early sign of glaucoma. There's no early signs of glaucoma. And one of the challenges here is that the patient will see very clearly in whatever vision is left. If they don't have, so if the patient doesn't wear eyeglasses and they can still read, they're just reading a little bit slower. They can still see pretty far away, clearly, but whatever's happening in the periphery is being lost. So it's most commonly patients won't notice that there's anything going on with their vision until it's too late, and that's why you need a checkup, because we will actually look for signs inside of the eye and put you through some tests that will tell us exactly how much vision you've lost, how fast you're losing your vision, and what we can do to do something about it.
What role sunglasses play in the protection of eyes? $10 billion business.
I love that question. So sunglasses are important because they block UV rays. UV rays have an effect of aging your eye quicker. So it's healthy to use sunglasses. I wear sunglasses. I know Elder Guillermo wears his sunglasses, and I hope that you are wearing your sunglasses as well. They help to prevent UV rays from affecting your eye, and they also protect the surface of the eye from wind, from dust, and anything that's in the environment. And they can even save you from a rock or two that is flying around and might hit your eye when someone is, I don't know, mowing their lawn or something like that. So it's sunglasses are a good idea, and investing in some good quality sunglasses with UV ray filters are an excellent investment, even for kids.
Thanks for an awesome presentation.
Gracias.
How often should we check our eye pressure?
So your doctor will check your eye pressure every time that you visit an eye doctor, and if he didn't, then you need to find a new eye doctor. It happens every 6 to 12 months, depending on your age and what your risk factors are. And if you're doing well, we might, move it to 2 or 3 years after you've had 2 or 3 yearly checkups that are completely okay. But this is something, like I said, that needs to be done it's not easy to check your eye pressure. Let me start by that. It's difficult to do. It's difficult to learn. So it's something that it needs to be done by a trained physician.
Dr. Gordon, are there more people diagnosed with glaucoma in the U.S. than other countries?
Well, that's a difficult question to answer. Diagnosis of glaucoma is more advanced in the U.S. than many developing countries, obviously, but it's believed that most people that suffer from glaucoma are either in the Caribbean or in Africa. So people would actually say that there's probably more glaucoma in places where there's more people of African descent than in the U.S. I have my I'm not so sure about that, but it's generally accepted that there's more glaucoma in Africa and the Caribbean than in the U.S.
Dr. Albany says, thank you. You remember him? All right.
Yes.
Yes.
Good to see you.
And Maria said, do you know about Neuro Lens? And you can read it. I'll leave the first part to you. There's a second and a third.
Can I just say that I just love my Kansas Avenue church? This is such an excellent question. I do know of Neuro Lens. I've actually been trying to find out if they're available around here in Mexico. So far, I haven't been able to. So Neuro Lens does in a machine what certain optometrists will do when they check your eye. Or what certain old school optometrists will do when they check your eye. So as an eye doctor and most optometrists, when we check your prescription for your eyeglass prescription, we're checking for 8 to 10 thins. This is what normal ophthalmology and optometry do, modern ophthalmology and optometry do. But back in the day, they used to check for almost 25 different measurements. So they used to, after they got your prescription right, they would measure if your eyes will deviate a little bit, or if they were well aligned, or if they separate correctly and work together as a unit correctly. It's not done in every case because the number of patients that actually suffer from this is not very high. So it's not cost effective to actually go looking for this in every single patient. However, if you're a person with symptoms that are mentioned in the Neuro Lens website, you might have your head might have a compensatory position, like people that look like this all the time, or you might be getting constant headaches, or you might fall asleep every time that you try to read, or get or you're trying to look at a screen and after you read you can't remember what you read. Excuse me.
That's it. Salud.
Gracias. In those cases, Neuro Lens is an excellent option and might actually be. I'm looking for it. I'm looking forward for it. It's something that you should definitely look into. They're expensive, but worth it.
All right, here we go. Dr. Gordon, this is very educational and helpful. Thanks for taking the time to share this information with us. The doc is taking care of some business there. I have a question for you, Doc, if you can hear me wherever you are. Can you hear me?
I can hear you. Sorry, I was coughing. I had a bad cough. Go ahead.
There's a question here. Is glaucoma more common in Black communities? Now, you had mentioned sort of individual, but in communities. And Black, they want to specify American Black. So let's keep it if you know that.
Okay, so here's how we got to that conclusion. Okay, let me say it is, or we believe that it is, but here's how we got to that conclusion. A group of physicians from, I think it was Kentucky University or some university down south, went to the Caribbean on vacations. They went to Bahamas, and it wasn't really a vacation. It was sort of a camp meeting, outreach activity. They saw a lot of people with glaucoma while they were there. So they said, wow, there's a high rate of glaucoma. Let's come and make a study. They went back, did a study of the population, left, and came back 10 years later and kind of did the same study. And then they found out that the rates were higher than they were elsewhere. At the same time, a lot of the people that have worked in Africa, in places where there's less resources, have seen that, a lot of their patients, when they come in to the clinic, not only have cataracts, but have glaucoma as well. So they can't help them because they have glaucoma. And it must be because I'm in Africa, or it must be because I was in the Caribbean. It must be because they're Black. I don't have any research that says that being Black will create this, but, because I saw it happen with so many Black people, then it must be because they're Black. Then they went ahead and did some studies in the US, and they found out that African Americans also had a higher rate of glaucoma. But, when you go into the details of those studies, they also had less access to care.
Okay.
And finally, once again, I knew I was going to get this question, so I went to look for any newer stuff, and I found a study where in a population where they have similar access to healthcare, Black people had 25% chance of progressing of progressive sight loss because of glaucoma versus 20% in people of European descent. So that kind of proved it. What can I tell you in summary? The reality is right now that we are at a higher risk of becoming blind because of glaucoma. I don't like particularly how they got to this conclusion. I don't share. I think that the methodology was not good enough to actually make that conclusion and say this is because you're black. I think there's a lot of things that we don't know. Remember, it's a group of diseases that end up with one thing. There's a wide range of genes here that we don't know what they do or where they are.
Mhm.
Having said that, because we are going blind at a higher rate than our brethren, we need to take care.
All
That's
right.
that's the bottom line. Let's just take care of.
All right, here we go. I think this is the second to the last question. Not sure if you have already addressed this, but is there common age when glaucoma can occur?
No, there's not a common age. We usually say that if you're over the age of 40, you're at more risk because there's a relationship between optic nerve loss and age. Having said that, there's a lot of young patients with glaucoma, so those need to be checked too. And the younger you are when you start with glaucoma, the more aggressive it will be, and the longer we have to keep you with functional sight. So the younger you are, the more aggressive will be in diagnosing it and in treating it. We might have patients that have the same pressure, the same amount of damage, and one patient is 40 and the other patient is 80. And I'll say to the patient that is 80, you know what? Don't worry about it. And with the patient that is 40, I'll say, we need to do surgery. We need to treat you. We really need to get on this because you're going to live another 40 years. And I don't want you to go blind before that.
So Doc, following up that, once diagnosed with glaucoma, how much time before a person either is disabled? Is that the same principle you're talking about, whether you're old or young?
Yes. So one of the main things that we do when we're trying to diagnose glaucoma is to actually establish what your rate of progression is. And that's why we never diagnose glaucoma with just one exam. We actually use a series of exams. So once we know how fast you're progressing, we know how aggressive we need to be with our treatments. There's types of glaucoma that can steal your eyesight in a matter of weeks. If your eye pressure is over 40, I need to handle that now. If it's over 60, I needed to handle that yesterday. If your glaucoma is 25, 26, then I might have more time, depending on how advanced your optic nerve damage is. It varies from patient to patient.
What about the type of glaucoma? Is there one type, or is there 7, 8, 9, 10? What, is there more type?
60-ish.
60-ish. Can you give us the ish? All right, give us the top three.
Oh, so the top three would be open angle glaucoma, angle closer glaucoma, and I'll say neovascular glaucoma. Those are the three main that we need to worry about. I don't know if we can see the video again for a second, and I'm going to try to pause it at a moment, just so I can show what the angle is.
There you go, Doc King.
I lost the image.
You
Sorry.
lost it? Okay.
Are you guys seeing the image? I can't.
No, we just saw the first part of it.
So let me see.
All right, here we go.
Okay. 3, 2, 1, pause. You can pause it now. Right there. Stop. So there, that's the angle between the cornea, which is the lens in front of the eye, and the iris, which is the color part of the eye. When that angle is open, when it has a wide angle, then we call it open angle glaucoma. When the angle is acute, when the angle is close, then we call that angle closer glaucoma. Angle closer glaucoma happens quickly. It happens fast, and it damages your sight quickly, and it's unmistakable. You'll have a red eye, a red painful eye, and you'll want to throw up. People will visit their doctors because of angle closer glaucoma. So we don't worry about it because we know that you're going to come. If you have this, you're going to show up at the clinic. Thankfully, it affects only about 5% of all the glaucomas. So this means that it affects maybe under 2% of people of the general population. It's it's not very common. The other type, open angle glaucoma, is what we were seeing in that video. And that's the one that affects mostly African Americans. That's the one that is asymptomatic. And that's the one that we need to worry about here. So open angle glaucoma is a lot more dangerous than angle closer glaucoma for our community. And then the third type I would say would be neovascular glaucoma, which is the one that's related to diabetes or intraocular hypoxia, lack of oxygen inside of the eye. Then you have congenital glaucoma, juvenile glaucoma, glaucoma that is related to certain drugs. You have traumatic glaucoma after certain accidents or even if you get punched in the eye or you're playing a sport and the ball hits your eye, that's the type of glaucoma that you would get from that sort of trauma. Glaucoma can be related to uveitis, to arthritis, to several other inflammatory diseases. It's a wide range of diseases that all have one thing in common, and that is the optic nerve becoming cupped, loosen its thickness, loosen its fibers, and that's the common thing.
Wow. So Doc, we have come to the end of our program. Can you summarize and give us a takeaway?
Sure. I'm going to try to share my slide again. That's my takeaway message. Have preventive checkups for yourself and for any family members that you have. That's the one thing that you need to do. If you guys remember that logo, that's the logo we did in October. Love your eyes. Go get your vision checked by a doctor. It can be an optometrist, it can be an ophthalmologist, that doesn't matter. But please go and have a preventive checkup. That's how we can find out if you have glaucoma, and how far along you are, and if we need to do anything else. And if you have glaucoma, then there's two things that I need you to do. Number one, visit your doctor yourself so you can ask them about new developments in treatment. And number two, get your family members to visit a doctor as well and find out if they have glaucoma.
Hey, Doc, thanks very much. I have a statement. We'll pray and we'll say adios. What does a black man, first of all, show you how the Middle Passage couldn't wipe us out. What does a black man in Mexico doing surgery? Well, I'll leave you alone. Doc, thank you for your willingness. As always, say hello to the family and let's have a word of prayer. That was awesome. Our Father and our God, we come to you thanking you for this life that you have blessed us with, the knowledge. Oh, it's awesome. I ask you to continue to bless Dr. Jason and his family, his wife, Ida Lines, the kids, and the family, the entire family, as they continue to minister all over the world, from Africa to Costa Rica to Mexico, United States. They have been there. Keep them safe, Lord. Help them to continue to be prosperous as they reach the world for Jesus Christ. In his name we pray. Amen. Doc, we hope to see you in America one of these days soon. And hopefully Dr. Morris will invite you to his pulpit where we see everybody preaching.